Hello, today we are going to revise cellular injury, and the first topic is cellular adaptations. We have five types of adaptations, which are all reversible changes. These are the changes that a cell undergoes when there is an increase in stress, decrease in stress, or a change in the stress. And if the stress is persistent, these adaptations can progress to irreversible injury or even neoplasia. And these adaptations are hypertrophy, hyperplasia, atrophy, metaplasia, and dysplasia. These changes can also be physiological, like the hypertrophy or hyperplasia of the uterus during pregnancy. Start off with hypertrophy. Hypertrophy is an increase in cell size due to increase in stress or the workload of the cell, as we see in cardiac hypertrophy. This is done by increasing transcription factors like NF80, GATA, and MEF2, which in turn increase the structural proteins or organelles. In cardiac hypertrophy, we see an increase in transcription factors like NF80 and GATA, which increase the cardiac myocyte size or hypertrophy, most commonly of the left ventricle, and if continued, would lead to heart failure. MEF2 is mostly used to increase the skeletal muscle size, as we see in the bodybuilders. Obstruction due to stones, we can see hypertrophy of the organ like gallstones, which lead to hypertrophy of the gallbladder. So next up is hyperplasia. This is an increase in the number of cells via controlled proliferation of stem cells and differentiated cells. Excessive estrogen production causes endometrial hyperplasia, which is caused by anovulation, obesity, or hormone replacement therapy. And if this hyperplasia is not reversed, it may progress to dysplasia and cancer. In men, excess DHT production can cause benign prostatic hyperplasia. And in certain cases, hypertrophy and hyperplasia are seen in the same organ. Like in the pregnant uterus, there is an increase in the cell size and increase in the cell number, but there is more hypertrophy than hyperplasia. In breast during pregnancy and puberty, there is an increase in cell number and an increase in cell size, but there is more hyperplasia than hypertrophy, but they're both seen in the same organ at the same time. Next one is atrophy. This is a decrease in the tissue mass due to increased degradation of the cytoskeleton via ubiquitin protease pathway and autophagy, where both of them lead to decreased protein synthesis or decrease in the number of cells via apoptosis. The causes of atrophy would be disuse, like when we immobilize the arm after a fracture, leading to wasting of the muscles of the arm, or denervation, like neurological disorders like ALS, when there is progressive loss of motor neurons, leading to muscle atrophy, or loss of blood supply, like to the heart, leading to ischemic atrophy, or loss of hormonal stimulation. Like in menopausal women, there is decreased estrogen production, leading to endometrial and vaginal atrophy, or poor nutrition like kwashiorkor and marasmus, when there is decreased calorie intake and the body breaks down its own muscle for energy. Next up, we have metaplasia, the reprogramming of stem cells to adapt to a new kind of stress, like chronic acid reflux into the esophagus, leading to Barrett's esophagus, where the normal squamous epithelium changes to columnar epithelium. And here we can see goblet cells in the esophagus, which normally produce mucin in the gastric mucosa. We can diagnose this histologically by taking a sample of the esophagus and using the Alcian blue stain, which detects the acidic mucin secreted by the goblet cells. We also have osseous metaplasia, like myositis ossificans, where there is formation of bone within muscle after trauma. The most common metaplasia is the respiratory metaplasia, where the ciliated columnar epithelium loses its cilia and is replaced by stratified squamous epithelium due to chronic smoking or vitamin A deficiency. This loss of cilia also decreases the mucus clearance, leading to increased respiratory infections. We also have apocrine metaplasia, which doesn't increase the risk of cancer. But the rest of the metaplasias do increase the risk of cancer, like Barrett's esophagus increases the risk of adenocarcinoma of the esophagus, or the respiratory metaplasia increases the chances of squamous cell lung cancer. And the last cellular adaptation is dysplasia. Dysplasia is not considered a true adaptation. This is a disordered, precancerous, usually confined to the epithelium growth, characterized by pleomorphism or the loss of uniformity of cell size, uniformity of cell shape, and tissue orientation, and also nuclear changes, which are increase in nuclear to cytoplasmic ratio and clumped chromatin. There are two types of dysplasias: moderate dysplasia, which do not involve the entire epithelium, and reversible if stress is alleviated. Severe dysplasias, mostly irreversible, and progress to carcinoma in situ. The major difference between dysplasia and neoplasia is that in dysplasia, the basement membrane is intact, whereas in neoplasia, there is a breach in the basement membrane and also loss of differentiation. That is, you cannot tell apart each cell. And that is the first topic of cellular injury, cellular adaptations. Thank you.